5, 4, 3, 2, 1. We are live now.
Good morning, everyone. So welcome on this pleasant Sunday morning. We are here to have the next session of Veteran Surgeons Forum. And I thank Dr. Gadegone sir and all the MOA office bearers for giving us this opportunity. Myself and Dr. Sangeet Gawhale, who would be the moderator for this session. I am the convener, Dr. R.M Chandak from Nagpur. We have a galaxy of excellent faculties. Dr. Sangeet himself would be talking on principles of managing infected non-union. Dr. Mangal Parihar sir from Mumbai would be taking us through the management of infected non-union, fixator, why and how, highlight when fixator is indispensable. So we'll be going through that excellent topic, when is the fixator useful. And then Dr. Milind Chaudhary would be taking us through tips, tricks, and recent advances in infected non-union, and how to deal with common problems associated with LRS and Elizarov. So we have all these good topics today, very interesting topics, and all of us are required to manage infected non-union. May I invite our MOA President, Dr. Wasudeo Gadegone sir, to address the meeting.
Thank you very much, Chandak sir. 1 minute, Dr. Pramod Shinde and 1 minute, Sandip Biraris will talk about this webinar. Pramod Shinde.
Most welcome, Pramod. Pramod, you unmute yourself. Unmute, Pramod. Please unmute.
Good morning, sir. I thank our President, Dr. Gadegone sir, for inviting such faculties, and we are having this MOA masterclass, and MOA members are very lucky that these academic sessions are going on. I wish all the best for today's masterclass. Thank you, sir.
Sandip.
Thank you.
Good morning, everyone. We are having very excellent program today, sharpen surgical skill and improve rationale, and infective non-union is the topic. And I would like to thank Gadegone sir for giving this opportunity, and Chandak sir also, and all the respected faculties, Dr. Sangeet Gawhale, Dr. Milind Chaudhary, Dr. Mangal Parihar sir, and Dr. Chandak sir.
So,
Dr. Gadegone sir, brief
yes,
about the MOA week, and this is the last day of that. Please.
welcome all dignitaries here. We are well-known speaker, nationally and internationally acclaimed. And to name Dr. Sangeet Gawhale, Dr. Chandak, Dr. Mangal Parihar, and Dr. Milind Chaudhary, they are not needing any introduction of me, because they themselves were very at a high level of academic stature. So we have also completed a Maharashtra Orthopaedic Foundation week, and it was well accepted by all Maharashtra Orthopaedic Association members as well as the viewers of OrthoTV. Now it is an endeavor to teach the upcoming surgeons, because our aim is sharpen surgical skill and improve patient outcome. So non-union still date, even after spending 40 years of my life, there are some puzzling issues which cannot be solved by only reading the textbook. We have to solve on the table. And such a stalwart like Mangal Parihar, Dr. Milind Chaudhary, Dr. Chandak, and Dr. Gawhale, they are all will share their experiences and enrich us with the bubbling knowledge. Thank you very much, and thank you for coming here to our master class of Maharashtra Orthopaedic Association. Thank you, sir.
Thank you, Gadegone sir. And may I now request Dr. Sangeet Gawhale to share the principles of management of infected non-union. Sangeet, please share your screen. So we invite all the questions on the chat box, and we'll be taking those questions as well.
Thank you very much, Dr. Chandak sir, Dr. Gadegone sir. It's a good topic to end the MOA week, a topic which is which we don't have a solution. And every one of us, those who are practicing either in the city or in the interior, faced with this issue, infection and a non-union of metaphysis or of the diaphysis of a long bone. I would be speaking on general principles related to the treatment, the problems. The surgical strategy in these infected non-union is based on these 5 principles. And these are the radical surgical debridement and deep tissue sampling, management of the dead space, stabilization of the bone, closure of the wound either directly or with soft tissue reconstruction, and appropriate antibiotic therapy, which is guided by culture results. I'll give various examples wherein all these principles, if neglected, what can happen, and if you address them, what would be the results. So this is a shaft femur which was operated some 4 or 5 months back, and after about patient had an infection, and the surgeon only opened the fracture site and put gentamicin beads along with some other antibiotics. But the discharge continued, no debridement was done, and the infection persisted. So ultimately, his nail and implants had to be removed. But at the end, you can see what has happened. The whole segment of the femur has got avascular, and that was a source of infection, and hence that had to be excised. The femur was stabilized by a fixator, and a cement spacer for a masculine technique was used here with appropriate cultured antibiotics. A good local debridement is a must whenever you're dealing with such type of infected non-union. After 6 weeks of cement spacer, patient was left with some amount of shortening. And once the biochemical markers were normal, he was grafted, and the fixation was used was a lateral plate. And at the end of 1 year, you can see how beautifully the non-union has healed. So if we follow the principles appropriately, one can get a union like this in a difficult situation. The second and most important part is that how far you should do a bony debridement. Like in a last case, what we saw was excising the proximal and distal end of the fragments, the fracture ends of the fragment adequately. If something is avascular, don't leave it behind. So if there are implants, you have to completely take care of the biofilm, which if it is a plate, it is over the plate and underneath the plate. All that fibrous tissue through the screw holes underneath the plate has to be excised. And if it is an intramedullary nail, all those membranes, the infected granulation tissue, the membrane which lines the medullary canal has to be rimmed and curated out meticulously, so that you don't leave any biofilm, you don't leave any colony, you don't leave any bacteria as far as possible. The bone gaps can be managed either by a Elizarov external fixator, monolateral fixator, or a free fibular transfer along with intramedullary or extramedullary implant. On both these topics, Dr. Mangal Parihar and Dr. Milind Chaudhary are going to speak individually. Very often what happens is when we have such compound fractures and if they are not adequately debrided, now you can see here there is an existing fracture gap, and subsequently what has happened is that segment has got necrosed. There was a drill hole made which was very close to the fracture, and that segment underwent avascular necrosis or infective necrosis. And this is the end result. So this, he had a significant shortening as well. So here it was treated by a cement spacer and a short plate, and then subsequently replaced by a intramedullary fibula. Proximally, the fibula has got incorporated, but distally it is taking a long time. This is at 1 year. Still, the problem, his problem is not solved. So whenever you are dealing with such large gaps, clearance of an infection and appropriate intercalary defect has to be addressed. Another situation where you can see here, this was a compound fracture. About 3A was the open type fracture, and there are multiple fragments. Probably they became avascular, the nail was exposed, and these avascular fragments had to be excised. Ultimately, he was left with an exposed nail, a bone gap of almost 14 centimeters. To reconstruct such a large gap is very difficult. A plastic surgeon was consulted, and he advised removal of the implant, cleaning of the wound, external fixator, and a microvascular free fab, which was executed like this. So again here, clearing all the infection, clearing the biofilm, clearing the granulation tissue, and leaving no dead bone underneath is the principle what one must follow, and then giving a good free flap, which will incorporate in an expected time. Once the flap was accepted, it took about 2 to 3 months. And once that settled, then we had to address the segment, which was 14 centimeter. So here we use a custom made interlocking nail and use that over which we transported the fragment to reduce the fixator time. This was custom made because there were 3 provisional holes made in the middle of the segment. This is how it was executed. After fixing the nail in the proximal and distal fragment, a corticotomy was done. The proximal distal fragment was fixed with 2 rings and the transporting fragment with a single ring, and the transport was started here. So once it progressed and the transport was complete, it was a time to remove the rings and lock the nail with the help of the screw so that the transported segment is stabilized. So here during that process, the transporting segment, it migrated a little bit up, and then subsequently the regenerate consolidated. The docking side had a non-union which had to be grafted. He also had a discharging sinus from one of the screws which was loose, which was removed. And at that stage where the union was not occurring, some cancellous graft was added. At the end of 1 year, everything healed. And at 4 years, this was his tibia, where a complete corticalization of the regenerate has happened. So also there is a complete union at the docking site. So here he is. And at 4 years, the nail was removed, and you can see the bone gap has been reconstructed by this method. And he's back to his work, but it took 4 years for all that. Another situation, infected non-union here. You can see the screws are loose. The patient is having a discharging sinus, and there is an avascular segment underneath where an interfrag screw has been used. So that required excision of that avascular fragment, clearance of the infection, and then subsequently a plate which was exchanged. All the implants were removed, previous implants were removed here, and a fibula was also used here to support the medial side. And at the end of about 1 year, you can see how beautifully it has healed. So if you follow the principle, you can get a good result in such difficult situation. The bony stabilization can be either retention of the fixation, provided it is stable, or either nail or plate, or a combination of both, or you can use a fixator, various type, which the subsequent speakers are going to speak. This is another situation, a 53 years old infected non-union. 1 year, patient had a shortening, osteoporosis, the screws have migrated inside, and patient was having a discharging sinus at the non-union site here. So this was exchanged with a cemented rod, and at 6 weeks, the cemented rod was removed along with the entire cement, the nail has migrated in the knee joint, so also the cement, which was all removed, and a combination of nail and plate here was used, and it is progressing to expected union after adequate stabilization and cleaning of the intramedullary canal. Wound closure can be managed either primarily by a skin closure or a free muscle flap or a local muscle flap or a fasciocutaneous flap to increase the blood supply in a avascular area. Appropriate antibiotics have to be started after doing the cultures. Most often in such long non-unions, which are over the period, no growths are seen. MRSA is another organism which is difficult to handle, and second most commonest organism is a staph, coagulase negative staphylococcus. Antibiotic therapy usually consists in a florid infection of 6 weeks of intravenous therapy followed by oral therapy for minimum 6 weeks or until early signs of radiological bony union are seen. This is not usually followed by all, depending on the local condition, depending on the amount of infection or a residue. Appropriately, this can be cut short to an individual patient. Often, we require a multidisciplinary team which comprises of orthopedic surgeon, plastic surgeon, radiologist, where there is a residual infection inside the medulla or in the soft tissue can be identified by a good radiologist with the help of an MRI, and accordingly you can address that issue whenever you're dealing with these non-union. And also for giving appropriate antibiotics, infectious disease physician is a must whenever we are handling such difficult non-unions. After having treated such patients, it is not the end of that.
Or neighboring country in China, Dr. Yi Lu, with an MD, PhD, and he's working in
some non-union. They still persist. There is at the docking site or at one of the sites, the non-union persists. There are residual deformities. Often at the regenerate or at the docking site, there are refractures or deformation, and some may have recurrent or persistent infection, and some of them may require amputation. So these are very difficult situations to handle, and if you individualize a patient and take care of the addressed issue, most of the problems can be solved in an expected way. Thank you very much.
Thank you, Sangeet. That was a wonderful overview. So any questions to Sangeet?
Sangeet, even after suppose there is a scarring and so many issues are there, and already the soft tissue problems are there, there is cicatrization, bone loss, and then we will contemplate again a major surgery like plating, and we have to again raise the all soft tissues and periosteum. So is there any issues of again there is a devascularization, and that may be leading into the some of the very delayed union. First case we have shown that is the plate was there, but it has broken at the lower side. If you see the fracture is united. So these are all issues are there, but it is very difficult to guarantee after giving so many treatment options also, and recurrence rate of infection is again a common thing. What is your experience?
Sir, in general, we cannot give any statement as regards the problem what you have. It's how is the overall health, age of the patient, the local conditions where whether you can address the soft tissue scarring or improve the vascularity of the soft tissue with the help of your plastic surgeon. But particularly in the tibia, we often come across such situations where on the anteromedial surface, which is subcutaneous, there is not adequate soft tissue. So probably instead of internal fixation, a ring fixator or acute docking can be tried in some situations wherein you can address or take care of the soft tissue problems.
Another issue that in infected non-union, even after debridement and so many, if you use a free fibular graft, that is also a vascular graft.
Cortical.
And when already a compromised vascular and there is a potential of infection, how far it is justified to put a free fibular graft in a non-union of the infected non-union, not in a aseptic non-union, in infected.
Infected. So that is, we have to judge as per the how the patient is behaving. The biochemical markers are helpful here. The local soft tissues, how they look at the end of about 6 weeks or 4 weeks following a prior treatment. And once you are 100% sure that there is no infection, then probably we can opt for that option. If we are not accustomed to ring fixators or other form of external fixator, probably that is an alternative. In the expert's hand, like Milind and Mangal, probably the solution is more of an acute shortening and then subsequent lengthening, rather than addressing this bone gaps with a free fibular graft, which is actually a cortical dead graft.
Question to Dr. Chaudhary and Dr. Parihar. So with your vast experience of managing infected non-union, what is your advice in Ilizarov methodology or mascule, and then stage 1 infection clearance, and then going for internal fixation with either plate or nail? So your own experiences and philosophy on this?
So yeah, please Mangal, go ahead.
No, you go ahead. I'll go up.
Okay, so Sangeet very nicely pointed out a lot of good things. And he said that you can try Ilizarov, you want to try Ilizarov. So this is like saying, somebody's a little bit pregnant. So you can't get a little bit pregnant. Either you are in it with the Ilizarov wholeheartedly,
Don't catch those words.
Sorry. Just can't help but point out to the impressionable minds that you can't try Ilizarov. You better be fully prepared. That's all I mean. With no disrespect meant. So in order to, it's you can't. That's the reason why Ilizarov doesn't work. If I were to try arthroplasty today, I'm sure I'll end up creating disasters. So
the reason for using, pardon me for that. The reason for using is, even if those who are doing Ilizarov, probably they think that putting those ring fixator will solve all the problem. But the basic is, unless you do a good debridement, unless you have an adequate soft tissue cover, or probably you address individual issues, where will you place the ring, the basics.
Yes.
It is not going to work in a common man's, probably you are experts. For a common orthopedic surgeon, trying out that would be,
I agree.
Unless you have that experience.
No, I think what Sangeet underlined was that there are two parts to an infected non-union. One is the infection and second is the non-union. And as I always like to say that in an infected non-union, if you can convert, even if you convert an infected non-union into a non-union, it's a success. We aim for getting everything in the first shot, but the primary thing is to get that infection out. So if you don't get the infection out, then you use titanium implants, you use Ilizarov, you use 6-axis, nothing is going to work. If you get the infection solved, then you have a much better chance of getting the non-union to heal by various methods. Sandip showed internal fixation. When there are gaps, I think basically bone transport of or a fibular transfer, live fibular transfer will work much better. I personally have not had very good results in my hands with a mascule.
Okay.
I don't know whether it's due to technique, but there are also papers which show that mascule doesn't work as well in terms of the tibia, whereas it seems to work better in the femur, and that's probably secondary to the good vasculature, good soft tissue covering, etc., that's available in the femur.
Okay. So with this, we come to the, yeah, go ahead, Sangeet.
Milind, what I meant to say is like the meaning of debridement today is probably so much of antibiotic spacer, antibiotic implants which are available. Inadequate debridement cannot substitute a local bead, stimulant, or a cement put inside around the infected non-union.
I agree.
So that is what is a concept, or probably Elizarov burns the infection.
No. That's complete nonsense.
So that is what I mean to say.
Yes, I agree. That is complete nonsense. Everybody must get rid of this, whatever they have heard, infection burns in the fire of the regenerate. It's complete nonsense. It only burns in the fire of the debridement. It's the oldest surgery. Debridement is the oldest surgery. It's the most useful and the most necessary surgery. And it should be done diligently. There's so many new tools that have come out for debridement. As a matter of fact, Kevin Tetzworth showed us that he uses dental mirrors, lots of high quality burrs, so you can look at the nooks and the crannies inside the cavities to be able to thoroughly debride. So debridement, really, I agree with you. It was just a light-hearted comment about the Elizarov, that one cannot take it lightly, that it's not going to work if you just, fiddle with it. You have to, go for it.
And with that good discussion, we now move on to the next lecture by Dr. Mangal Parihar, and he'll take us to fixator, why and how, and when the fixator becomes indispensable. I think most welcome, Mangal sir.
Thank you. So essentially, I think Sangeet underlined the fact that if there is no gap, and if you are able to do a good debridement and ensure that there is no infection prior to going in again, then there is always a role for internal fixation, especially if your soft tissue cover is good. If your soft tissue cover is not good, then you have to do some form of a plastic procedure and then proceed with internal fixation. So the place where a fixator is almost indispensable is if you've got large gaps, 3, 4, 5 centimeter gaps, you could still probably attempt a mascule. But if you've got large gaps, if you've got poor soft tissue, if you are challenged in the sense that there is not adequate support, say from plastic surgeons, etc., if you're in a smaller place, which is becoming lesser and lesser, I think, because nowadays you have good specialists in even smaller cities in that sense. But wherever there is a gap, like in this patient who came with an open fracture a little late, and he had this fixator put on, and there was this exposed bone, and this goes with what Sangeet was saying. Now, oftentimes what will happen is you can use a plastic surgeon to cover up this exposed bone with the hope that we won't increase the gap further, but that is almost fatal as far as the principle of treating infection goes. This is dead bone. That dead bone has to come out. When that dead bone comes out, then your apparent gap, which seems relatively okay now, becomes much bigger, right? And therefore, in that situation, the only reliable thing that will sort of work is a bone transport. Now, you can use an Elizarov, and you can also use the principle of Elizarov with a unilateral fixator like this. Basically, bone transport requires stable fixation, which is provided by these kind of LRS type of fixators, and regular distraction on a stable frame. That will almost always lead to bone formation. So this guy, over a period of a month, and then over a period of 3 months, you can see the fragment has been transported and docked inside. Give attention to this portion here, where that fragment is sort of going into the into the distal fragment. And that is something I try to set up as far as possible when I'm putting the fixator on. I'll show you exactly what I mean when I'm talking about that. So once that is docked over there, usually we need to do a bone grafting. And all of these gaps will take a long time. Even if you treat it with a microvascular fibula, even if the cases which Sangeet showed, you treat it with internal fixation, time to union is always prolonged because these are difficult biological situations. But with fixators properly applied, patients can remain pretty functional in the duration of their treatment. So at the end of 1 year, this guy is completely healed, solid, and ready for the fixator removal. So the advantage of bone transport, it is one solution for a whole spectrum of injuries in whatever bone that you can think of. More often than not, it is a single solution. You do the debridement well, get rid of the infection, put on the fixator, and that will sort out the problem, though it may take a little longer time. And the more you have problems with soft tissue, infection, and large gaps, the more is the advantage. So though that is really what I would say is when the fixator is indispensable. There are negatives ascribed to it also, which personally I don't really call them negatives, but they're part of the treatment, that it takes a long time. You will have docking problems. You may have pin side problems, but these are mainly, the pin side problems are mainly related to your technique in terms of how you put in the pin sides. And there can be issues of healing the non-union. Many a time, people tend to think that putting on an Elizarov fixator or an LRS fixator is a passport to success. No, if you don't put it on properly, if you don't monitor it properly, you're not going to have a good result. So how do I try and avoid problems? The first one is alignment. Many a time when we are conducting courses or on WhatsApp, etc., people will send us pictures of where there is a mismatch or the transported fragment is deviating. And then to get around that, a lot of people talk about putting in an intramedullary wire and things like that. I haven't used an intramedullary wire in my life, actually, for most situations, for simple bone transport situations. Essentially, you have to see when you're putting the fixator on that it is aligned well on the AP and aligned well on the lateral. So when we are putting on the fixator, if it's an LRS, for example, the moment you put in your first pin in the proximal segment and the distal pin in the distal segment, if this one is perpendicular to the fragment and this one is perpendicular to the fragment, essentially you have fixed your alignment on the AP X-ray. Now in infected non-unions which have been there for a long time, the place that it can have a problem is in the lateral view, because these patients will have some element of equinus. There will be some element of posterior sag. So before you put in your second and third pins, which would, the third and the fourth pins, which would be closest to the fracture, and this one over here, you have to ensure that the alignment on the lateral view is good, because the fragments can still move around those two pins that you have put. And there are different ways to achieve that. You can keep a bump under the apex of that angulation, a bunch of towels maybe. Another thing I find useful is to get the assistant, especially if there's a little bit of equinus, is to get the assistant to pull the foot more into equinus. And that corrects that posterior sag. The tendency of the assistant is to keep the foot neutral or dorsiflex. In fact, they should pull it into equinus, so that will then correct that. And the moment you have put in your second, your third and your fourth pin, essentially you have locked the position of the fixator. This is when I'm talking of a LRS but essentially similar when we talk about a ring fixator. Then what I try to do, as I pointed out there, is to get a little bit of cortical mismatch. On the LRS, it's easy. You can just pull one set of pins a little this way, push one set of pins a little inside, and you can get this kind of cortical mismatch. What I do is I keep a long K wire on the edge of that proximal fragment and then screen down with an image intensifier. So I get an idea of where this is going to come and hit, because you can never see the whole thing on a C-arm, even if you have a 9-inch C-arm. So the advantage of this is, if this had been perfectly matched, then I would have got sort of a point contact. Whereas here, if you notice, this apex tends to get into that medullary cavity, and depending on the shape of the fragments, you can play with that, so that there is more stability, there is more contact and more area for healing. Now, when I'm doing an Elizarov, I want to see that the ring is parallel to the proximal and parallel to the distal. So either it's parallel to the joint line, or I only put in one wire here, or the rods are parallel to the shaft. So I fix my proximal fragment reasonably okay. If I don't find this, I will have to change the direction of the wire to ensure that it is proper. Now, when I come down, my ring should be parallel to the distal joint. And if it is, then I will put it. So this is similar to what I talked about on the LRS, number 1 and number 2. First fixation, second fixation, I have fixed up my AP view. And similarly on the lateral, before I put in any fixation at this point or at this point, I will ensure that this is aligned. And this is what I was talking about. I will keep a K wire and then come down looking as to, okay, what is the relationship of the center here to the center here. Same thing on the lateral. I want to see that this is well aligned. If this is well aligned, then I'm not going to have any problem while doing the transport. And this is the cortex docking projection which I was talking about. So here you can see that the anterior is slightly ahead, or if this line, and the cortex of the anterior is ahead. So I'm going to get a little bit of mismatch, which is what I'm usually looking for. So with a proper alignment on the AP, even such a large distance and such a small fragment over a period of time, there's no problem in reliably moving it down. And you can see all the while there is a good bone formation occurring. On the lateral, again, it's the same. You don't need wires. You need to pay attention to what it is that you are doing, and that your fixator is appropriately aligned in terms of the bone. So now here you can see this malalignment or cortical mismatch is helping me to get a certain bone, one into the other. The other thing sometimes is if your bone ends are not transverse. And I'm not a big fan of getting the bone ends transverse, because when you get bone ends transverse, essentially you're shortening the bone a little. So you're adding in terms of time. I would rather, in situations like this, when the bone has come close to each other, I will open it, do an oblique fibular osteotomy or excise part of the fibula if required, and then open hitch those fragments into each other. So that is internal stability as well as a broader base in terms of the healing. So the likelihood of fractures in once the fixator is removed in this non-union area is reduced. And I will always, if I'm opening it, I will take the opportunity to graft it also. So you can see how well this hitched ends heal up. You can make the bone ends flat in certain situations where there's so much of infection. So now I don't know which part of this bone is proper or not. So there I will tend to take off all of this in toto and get flat ends, which will give me good in terms of healing. The other issue which always happens or often happens in these long transports is the soft tissue invagination. And it's not really a problem in the sense it is a part of the process. You know that when you have bad soft tissue like this, as you get the fragments in towards each other, this soft tissue is going to invaginate. There are many smart ideas in terms of putting wires under the skin and trying to lift it up, etc. I find it's much easier. Let it come as it is, and then when you need to dock it, perform a surgery which will clear up that area. I'll show you exactly what I mean. So here you can see the amount of fibrosis in this lady who had this distraction. The bone transport going on over here. This is probably the one place where I would use an intramedullary wire, and the reason being that all of that fibrosis underneath that skin is going to severely hamper the movement of that fragment, number one. And number two, distally here, we've got very poor hold. The quality of the bone is not good. The fragment is very small, etc. So here, you notice that the distraction is proceeding well. We are getting compression over there. And these are the pre-docking X-rays. Right? So at this point in time, with all of that fibrosis, that skin has invaginated because it's held down. It's all fibrotic over here. So it's not going to allow that bone to transport. The bone just pushes that skin, inside into that valley, and you can see the deep depth of that invagination which has occurred. So at this time, the solution is to excise that skin and soft tissue in toto as a block, and excise some of the bone beyond that margin of skin. So again, you have relatively more of a bone defect than a soft tissue defect. Essentially, you get redundant soft tissue. So if you now get that bone together, you are not going to have too much of tension on the soft tissue. So this is the amount of soft tissue that is planned to be excised. First of all, because it's invaginated. Also, this is very thin, papery, poor quality of soft tissue. That's on the AP and that's on the lateral. And then we do this acute compression. For acute compression, you always have to do either a very oblique fibular osteotomy or a excision of part of the fibula. I usually prefer an oblique fibular osteotomy because I don't have to take out too much of the fibula. But essentially now we've got these fragments docked into each other, graft has been added, and we have been able to get relatively better soft tissue which is apposed to each other over that non-union area. And this is the post-docking X-ray, and that is the quality of the healing. Again, as I said, bone grafting, I don't shy away from bone grafting whenever I have opened it. The other trick that can be used to avoid these issues of bone transport, especially for relatively smaller gaps, is the concept of acute docking and lengthening, or acute shortening and lengthening. But this is, as I said, for smaller gaps. You should have a reasonably good vascularity and not very fibrotic soft tissues, because if you do have very fibrotic soft tissues, they will not allow easy acute shortening, and a lot of fibrosis can also lead to issues relative to the vascularity. So the difference here is if you have a fixator setup like this, in shorten and lengthen, you are shortening between ring number 2 and 3 and doing a separate osteotomy here and lengthening between 1 and 2. Whereas, so the effective length of the fixator reduces and then increases. In a transport, also known as an internal transport, your ring 1 relative to ring 4, the length remains constant. And you just have ring 2, which is moving down. As it moves down, it closes this gap and opens up the regenerate gap. The advantage is then you don't have these issues of docking, etc. You can do all the docking procedures right away on table. So this was a non-union with infection. So we've excised the infected area, cleared the infection, excised some part of the bone, and shortened that area of the bone, and then lengthened it through an osteotomy, which is lower down. So then I don't have to bother about all of those issues related to bone transport. And here is why I like to do an oblique fibular osteotomy. When you do an oblique fibular osteotomy like this, you don't need complicated calculations to find out whether the length has been restored or not. All you have to see is on the X-ray, the fibula now has come out again to length. So this osteotomy for the fibula has to be done by a power saw. You're doing it with a osteotome will tend to sort of create spikes and spicules, which will not allow easy sliding. So here, as we lengthen it, you'll see that the fibula is now coming out to length. And once the fibula has come out to length, then I can confirm it by doing a full length X-ray. So during this lengthening, this part remains in under compression, and that has healed off well. Regenerate also fills up well. So in sort of conclusion, bone transport when poor soft tissues, so it tends to be more in that sense, in the lower limb, at least in the tibia, because there tend to be more soft tissue issues with the tibia. Whenever you have infection, and especially if you are not at, the first few times when you're doing infected non-unions, if you're not sure of your technique, then the fixator becomes a sort of benefit. Not to say that you can get away with this thing, but if you have, you can get away with poor debridement. But if you have a fixator, if you have metal inside and the slightest screw up in your technique, then the chance of that infection. So whenever I hear people saying, I've done a debridement and I'm waiting for the infection to settle down, in my mind, I say you've not done a debridement, because infection has settled down the moment you've done your debridement. Yes, we give them additional antibiotics, etc. But that phrase itself, waiting for the infection to settle down, is a little dangerous phrase. So when you have large gaps, use the right kind of fixator. I mean, just because you can't do an Ilizarov, if you got a small fragment like the lady with the poor soft tissue that I showed, there's no way that you can use an LRS over there. So there is no fight between an Ilizarov and an LRS. It is what fixator is adequate for the purpose. So the smaller the fragment, more difficult the situation, or poorer the quality of the bone, the more I would tend towards using a Ilizarov. And how to do it is, as I said, take care of alignment when you put on the fixator. The rings or pins should be perpendicular or parallel depending on what the case is, and pay a lot of attention to pin insertion technique. The pins have to be the right size. They have to be put in appropriately, because these fixators are not the 3-week, 4-week fixators of compound fractures. They are fixators which are going to stay on for at least 6 to 8 months, if not a year, as in that particular case that I showed you. Thank you. So, okay, one more is in small gaps, you can consider acute shortening. I said the shape of the bone ends to get internal stability. I always rely on excision of soft tissue invagination. It's one small additional procedure. If I have to open it, I will always bone graft it, and not to forget the importance of rehabilitation in terms of range of motion and weight bearing. Thank you.
Thank you, sir. That was wonderful. And you gave a nice concept about maintaining the axis and having a mismatch of contact. That was something of great importance, as you have said. Any opinion on this, Sangeet?
Yeah,
Cortical mismatch?
when you are transporting, it is easy to manipulate the transporting segment with a LRS. How do you do it when you have a circular fixator? It will be, that it is much easier with LRS rather than the circular fixator, unless you have used hinges. Otherwise, extension plate where you'll have to shift the ring, transporting ring outside.
No. So that's what I'm saying. So that is why I pay most attention to getting it perfectly aligned on table. I don't want it shifting later on. It's not to say that there are no cases where I have to adjust it later on, but I would say that would be one case out of 10 or something very, very difficult. But otherwise, for the plain and simple ones, I will try to get them aligned the way I showed you on that X-ray. So then I don't have to play around with it. So if I find on table that was one fragment is misaligned, then I will put in the wire again to ensure that this alignment is perfect on the AP. Then go to the lateral, ensure that the alignment is okay, and then put in my number 3 and number 4 wires, let us say. In spite of that, yes, occasionally you may have issues, but that is generally adjusted when we come to the point of docking. Suppose we've got a little bit of angulation. So then when we've opened it, we can get it aligned sort of open, put both of them together, and then the rings are fixed to each other with coupled washers.
Okay.
So that's done sort of acutely, not gradually.
And second issue is after you put the pins in the proximal, the transporting and the distal fragment and fix them with either a LRS or with a circular fixator. And when you do the corticotomy, it usually displaces. So then what you have calculated earlier before a corticotomy and after doing corticotomy where it slightly displaces.
Yes.
So then your alignment would change.
Yes and no. So when a corticotomy displaces, it basically means unseen stress in the system. Okay. So if you had something, the pins like this, the pins were like this, and you stressed it into this position. Now, once the osteotomy is done, that osteotomy is going to displace. So oftentimes when I'm doing deformity correction, before we do the osteotomy, we open out the hinges. So I will show off to the fellows that, see, there is no displacement between the hinges, which basically means that I have not put in any stress in the system. So stress in the system comes if you bring the wire to the ring, or you have a pin which is slightly oblique and you force it into a different position. So this is something which has to be, sort of regularly audited. And if you know that, yes, this osteotomy has displaced because I have put stress into the system, next time, hopefully it doesn't happen. Now, worst case scenario, it has happened. Now what? Then you keep going till you get to the transport time, and then you have to adjust it.
Okay. What is your experience about the quality of regenerate and the column of regenerate in LRS versus Elizaro? Are they both same behavior?
Yeah, you saw some examples also. They are both the same. It's more to do with stability of the frame, rate of distraction. Now, for example, I showed you one patient where I did a distal osteotomy. There, I wouldn't do a 1 millimeter per day. I would do 0.75 millimeters a day.
Okay.
And then if things are going really well, only then. But more often than not, for distal tibia, I will go only 0.75. Somewhere where I'm worried, I may start at 0.5 per day. And when the regenerate is showing a good amount, then I will speed it up. But otherwise, there is no difference, really speaking, between the LRS and the Elizarov. In difficulty, what happens is, difficult situation, small fragment, osteoporotic fragment, there the Elizarov would be my preferred fixator.
Okay. Yeah.
But not because it gives me better regenerate, because it gives me better hold in those small fragments and poor bone.
Got the point.
Sir, may I have one question?
Yeah, please.
Mangal sir.
Yes, sir.
So how you are talked about external soft tissue invagination.
Yes.
But it is sometime in a large gap, and when there is a soft tissue cover is there, and if you want to do a bone transport, there is a possibility that the soft tissue invagination also is inside. So is there any obstacle in during a bone transport, because it has to travel through that fibrous and invaginated soft tissues? So
Yes.
Then how to tackle that obstacle?
No, so usually that it ultimately lands up into this only, like it lands up into something like this. See, I'll just let me just share my screen for a moment. I'll show you
I have just an extension of the same question. Probably you can address that together. Is the regenerate different when you have a flap regenerate or a docking site healing? Is it different when you have a scar tissue, something like in which you have done excision of the invaginated tissue, and the one which has a flap? And second is, your rate of distraction would be same if you have that scar tissue and a flap or a normal soft tissue, which is supple, which is not adhered to either a corticotomy site or a docking site.
That's always a good skin is always better. But in terms of regenerate and poor soft tissue, I have not really had a problem. But in terms of a non-union site, yes. That's why, as I was pointing out there, the invagination was maybe 3 millimeters, 4 millimeters. But I was trying to excise almost a centimeter of skin all around, because that was terribly, scarred soft tissue. So I said, now I'm going to excise all of that and have, relatively speaking, supple soft tissue, which I can cover over that. So I think, see, basically our principles don't change. Only thing is, with the Elizarov, you get a little more leeway in terms of thoda sa patli gali se nikal jana kind of thing. So here is an example. This is
by supple, what you shown in the diagram was only excising what is invaginated.
No. It is actually more than the invagination.
Okay. But not undermining or freeing the soft tissue from the bone, so that you get a free flap.
To a certain extent, I have to free it if I want to excise the bone further beyond the skin edge.
Yes.
I have excised the skin edge this much, right? And then I want to excise further bone. So I have to raise that soft tissue a little bit, excise the bone further. So now when the bone comes together, this soft tissue is apposing without tension. I don't have to sort of pull it together.
Okay.
This is that long transport I showed you. This is his skin, right? And this was a poor soft tissue defect, which we have grafted, skin grafted, to get closure. Now we've done the transport, and as we come down, you can see that this edge of bone, this has actually gone underneath. And all of this soft tissue is still adherent down. This is what Dr. Gadegone was pointing out. Now, once we have come to this level, then what we did was a rotation flap to get rid of that, because under split thickness, it's not going to go under. So I will generally prefer to do this rather than do a flap before. So the plastic surgeon raised the flap, sutured it back, and then continued the distraction. Then we excised all of that soft tissue, and the flap was rotated. So this was all, here was all skin graft. Underneath was all skin graft. So all of that has been excised. the bone ends have been sort of made transverse and not transverse. They've been freshened and hitched with that fibular osteotomy that you can see over there, and the flap has been closed on that. So if there's a large amount of invagination, or if there's a very bad skin, then yes, some kind of soft tissue cover will help. So that's the same actually patient, and that's how he healed.
Perfect. I think after that wonderful lecture, we now move ahead, and Dr. Chaudhary would be sharing his tips and tricks for management of reliable treatment of bone gaps, and then he'll be covering up tips and tricks for recent advances in infected nonunion. So welcome, sir.
Good morning, everyone. Thank you very much, Maharashtra Orthopaedic Association, Dr. Chandak, Professor Gadegone, for a very kind invitation to participate. In the interest of completion and in the interest of preventing overlap between the topics, I have changed my presentation a little bit because it has become bone gap centric, even though I had given my topic as bone gaps only, presuming that the infected nonunions would be covered.
Yes.
So let me begin with the basics, only building up on what Professor Sangeet Gawhale has already very nicely told you. But there is a certain element about infected nonunions which is missing from the literature and from the clinical practice. In which case, so Dr. Sangeet Gawhale showed us very nicely how we did a bone transport with an intramedullary nail. So the question is, in which case of infected nonunion can you get away with internal fixation later on, whether you can do a bone transport over a nail, a bone transport over a plate, or whether you can use a mascalase technique with an internal fixation. And in which cases you're likely to get a recrudescence of infection and you're going to suffer from, a failure and a problem. So this is a question that has been bugging me for the last 15 years. So we came up with a certain classification. So let me start. So infected nonunions, we know, have all these elements. There's deformity, there's shortening, there's bone gaps, there's contractures. And the orthopedic surgeon has to be able to learn them all, has to be a jack of all these problems and to master them all. And the two big bad jokers in this scenario are joint stiffness and social isolation. So the joint stiffness is what leads to the maximum disability. So if you look at the SF36 scores or the other patient-reported outcome measures, they say that the disability arising from a non-union or an infected non-union is as bad as that or worse than that coming from a chronic renal failure. That's chiefly because of the joint stiffness, the difficulty in ambulation, and the inability to participate in social enterprises, activities, employment, and a loss of earnings. So we have to look into these issues as well. Now, the question that really we need to look at, all the techniques have been discussed. There's nothing possibly too much new to talk about debridement. But which infection is worse? How will you promise the patient? How will you tell the patient? How long will the infection take? Will you need one debridement or will you need two debridements? That is the essential question, and just the amount of, just the blood parameters may not give us. So we came across this infection severity score, which we wrote up in the Indian Journal of Orthopaedics in the year 2017. And we have 6 criteria. We have the skin, whether the skin is flexible, pliable, and well nourished, or whether there are, it's papery thin or adherent. How many sinuses do we have? How much discharge do we have from the wound? Whether it's a small amount, a tiny drop coming out every once in a while, or is it a copious, florid, extremely horribly smelling discharge, and the patient may need reams of newspapers under his limb to soak up all the horrid discharge that's coming out. So these are not the same infections. How many sequestra are there? Is there a large sequestrum? Is there a tiny sequestrum? Are there multiple sequestrae? What are the implants that are present? Is there an intramedullary implant? Is there an extramedullary implant like a plate, or is there a combination? Or did the patient have no implant at all? And depending upon what is the kind of anticipated treatment needed. So the infection severity score, we have given 1, 2, 3, 4, 5 points. If the skin is supple, it gets 1 point. If there are many discharging sinuses, we're going to give 3 points to this patient. If there is a large circumferential sequestrum, he gets 5 points. And if there is a copious discharge with more than one dressing needed per day, and there's a foul smell, you can give him 7 points. And if the patient has a plating as well as a nailing, he gets 5 points. And if the treatment needed is more than you anticipate, more than one debridement, he's going to get 5 points. So this adds up to 25. We multiply by 4 to give him a score out of 100. And if he is going to get a score more than 75 by a classification by Giannudis, they advise amputation. Whereas we have salvaged most patients who have more than. So, how do you anticipate the amount of difficulties in the treatment based on the presenting X-ray? So the level of difficulty score is also there. So when the patient walks into your consulting chamber, you can tell him, look, you're going to need 2 debridements. Look, this is a really difficult non-union because you have a gap more than say 6 centimeters, because the amount of bony contact between the non-union ends is less than 50%, because there is a defect larger than 50%, because you're a smoker, and because you are shortening more than 6 centimeters. So you are forewarned. And you can tell the patient this is going to take multiple surgeries, 2 surgeries for debridement, multiple surgeries, you're going to need bone grafting, you're going to need an Ilizarov fixator, so on and so forth. So we have all these scores. So if the infection severity score is low, as it was in this subtrochanteric non-union, we could get away with a temporary external fixator, a cement rod to cure the infection, and then we fixed him with a locking nail. He didn't get a recurrence of infection because his infection severity score was low. Whereas the same thing done for a severe infection would end up in a recrudescence, which is a shame and a disaster. So this is an orthopedic surgeon who got an infected non-union of the tibia, received the highest antibiotics in the land for 11 months. But by the time he came to us, the infection had almost burnt out. And all he needed was an all-wire Ilizarov frame. And I used only ampicillin and cloxacillin. This was done more than 20 years ago. And he needed the trampoline effect of the frame. While he was under treatment, he worked as a clinical fellow. He worked throughout the day. And you can see the excellent mobility and stability he has. And he was able to achieve union without bone grafting, even though he was previously infected, because his infection severity score was low. This is his union. He continues to remain united without any trouble for the last 20 years. This is an orthopedic surgeon who had an infected ankle arthrodesis. So he has discharging sinuses. He has a high score. So we can't fool around with him. So we do a debridement, add cement rods, and then add the Ilizarov, add a little bit of lengthening to improve the vascularity and get him to unite. And he stays united after 20 years. What happens if you have, now let's come to the other factors. So I'm trying to fill in the gaps in this symposium, in the gaps in the knowledge that have been left uncovered. So what happens, the typical problems, why does the Ilizarov fail? It's not just because of the casual surgeon. Even if somebody is doing a lot of Ilizarovs, you can fail. This is a young neurologist who studied in Russia 10 years ago, and he had multiple failed surgeries. This is a large cement bone block. They took care of the infection, and this is the kind of surgery he had. But the problem that he really had in achieving union was that he has oblique joint surfaces. And you can see over here the oblique nature of the joint surface. And this is his joint. Sorry about that. So all we have to make sure is that we are not giving a vertical compression, which is going to make the non-union surfaces slide off each other. We need to get perpendicular compression, so that it's anterior-posterior compression in this case. This animation, I'm not sure is working, but that's how. So we gave him some lengthening, and we got him from posterior to anterior compression, and he reliably united. So now let me look at this. So that was the shape and the direction of the non-union. Now let's come to another important aspect in juxta-articular non-unions. This is a 75-year-old, grandpa with multiple comorbidities. He had a total knee replacement. He had an infected non-union of the distal tibia. But the essential element that was going on with him was that there was a minor amount of procurvatum deformity at this small non-union surface. And this is what leads to excessive forces and a bending in shear forces, which may be difficult to control with an Elizaro, or if you just put in a plate, your multiply operated patient, the plate and multiple screws may not give a hold in the small, soft osteoporotic bone, which has already got multiple holes. So we use the TSF fixator to ensure that there is no procurvatum, and you can see over here, there is no procurvatum deformity remaining. Accurately, it is repositioned with the TSF fixator, and that is how we get him to unite. He's wearing a brace for a while, and he lived for another 10 years after successful treatment of his non-union. So this is about deformities. Now, the next important parameter that's not been touched upon is the contractures in the presence of infected non-unions. This gentleman has a horrid infected non-union with sclerosis, fibrosis. What's going on here? There's a fixed flexion deformity of the knee, and there is a recurvatum deformity in the tibia. Look at this. So in the first stage, he gets a debridement, he gets an ABC rod as well as beads, and you can watch the amount of flexion in the knee and the recurvatum in the upper tibia. So when we put on the frame, we extend the frame above the knee. This is what you have to frequently do. Extend the frame above the knee, extend the frame below the ankle in order to augment the stability, and then also correct the contractures. So posterior distraction at the end of the knee help to correct the FFD. Anterior distraction help to correct the recurvatum. And this is how he united with very minimal deformities and no recurrence of infection. So now I will come back to the original. I will come back to the original presentation I had made, because there were elements of gap in the three presentations that we had planned. So I'll come back to my original presentation. And there's two aspects to treatment of bone gaps. One is, how do you treat bone gaps when the infection is completely controlled? When they come to you after chronic osteomyelitis in childhood, and then we have a lot of residual gaps to deal with. So very quickly, I'll come to a few examples of this. So a fibula is a friend when the infection has burnt out. In simple cases in young children, a fibula and a cast will do the job, as most of us in public hospitals have learned to do. This is here she is with a wire and a shoulder spica, and she healed up. But when you come to a difficult problem like this, just the fibula is not going to work. This child never walked in his life. He's 1.5 years of age. He's got this massive gap in the femur. So when we just put in the fibula and the wire and a spica, it didn't work. What's needed is this unbeatable combination of the fibula and the fixator. And that's how we did it. So he had a fibula, he had a fixator, he had a proximal corticotomy lengthening, and we ensured that the fibula was getting compressed. And this is how he is. And for the first time in his life, he walked really well, and his gap is completely healed up. Of course, he's going to come to us later for further lengthening because of the growth arrest of the distal femoral physis. It's a small price to pay. And this is a limb that's turned around completely with shortening. We use the fibula to fill up the gap in the upper end, derotated and lengthened at the lower end to give him a sound union and a straight limb. We also used long ago, 25 years ago, a mother's fibula in this case, in this child. We put on the fixator, increased the gap because the fibula had overridden, used the mother's fibula, filled up the gap, got her to unite. And as she grew, we continued to perform, to monitor her, perform minor surgeries, a second repeat lengthening, a fibular osteotomy, epiphysiodesis of the fibula because it was growing longer than the distal tibia like this. She continued to grow into a beautiful young lady. And then finally, we lengthened her in the last stage to give her equal leg lengths. So from a large gap in the tibia to somebody who has an essentially normal limb over all these years is possible with the Elizaro. Again, in young children, we do bifocal treatment, we lengthen them, we heal them, we give solid, reliable union. Now, what happens when you have an acute, subacute traumatic gap like this? Now, instead of using a temporary fixator, using debridement, and then switching to intramedullary nailing or plating, which is multiple surgeries, multiple costs, I believe in the monofocal or the mono treatment with the Elizaro. So we use an Elizaro, we use a combination of antibiotic cement beads, we used the cement beads in the beginning, multiple debridements. We also used a vac to ensure that the wounds healed really well and that he didn't have to have lots of dressings. Then we used a cement block. And then finally, we converted it to a bone transport. You notice here the foot frame and the ability to walk. Notice here is that this is a young man who looks strong because he has good nourishment, and he got more than 17 centimeters of transport. And he really did well in barely 14 months of treatment. And this is his result. He works in the mines of Jharkhand, and he has no problem with his limb, no infection, no deformity, no residual shortening. We see these things. Young surgeons are tempted to perform plating in compound fractures. This is what can happen. This gentleman came and he ended up with a massive gap like this, more than 17, 18 centimeters. And it really took a long time because Mangal has spoken at length about how to achieve the alignment. I'm not going to go into these details, but it requires a lot of patience and time in the minor operation theater, the treatment area. You have to use sometimes very thin pins. You have to allow sclerotic bone to remain just in order to get a grip on the transported fragment. You have to extend the fixator onto the femur and then get this gentleman to unite like this, even though the skin is thin and friable. Again, some more examples of burnt out infection and gaps. So however small the fragment, you can lengthen. So this is a hash fixation. This is this is how we fix it. And even with tiny fragments, we can transport it and get it to unite, lengthen the tibia as well to give her 23 centimeters. Now, coming to the question that Dr. Chandak asked about, do you prefer Mascale or Elizaro? So I believe that the topic of my talk is reliable treatment. Now, the Mascale is a hit and miss if you do not identify which infection is severe. If you have identified that the infection is not severe, with one debridement and a proper culture and antibiotics, you could get away with a Mascale. So in this young man, he had a bone gap. So we chose to perform a Mascale. I know Dr. Chandak has the reamer irrigator aspirator. I also had a system, the RIA system, and I chose to try and heal up this gap with the RIA, bone graft. Because the thing with Mascales is that there is a lot of cost of the bone graft that you need to harvest or synthetic grafts. And what happened? We got a lot of graft from the RIA system. He had a precipitous fall of his blood pressure, which we managed and filled up the gap like this. But to our dismay, it completely vanished in front of our eyes in the next few days because he had some reliable treatment. And the Elizaro, because it is parfocal, it is away from the focus of infection, the regenerate forms well if you, regardless of the Elizaro or the TSF or the LRS fixator, and you slowly get the gap to heal up like this, and you are rewarded with complete cure of infection and a reliable treatment and filling up of the bone gap. Now, the microvascular surgery is a saver, especially in the upper extremity, I think, where weight-bearing elements are not involved. This is a gap in the radius. In the first stage, we debrided and use the fixator to bring the radius out to length, maintain the DRUJ, and then perform a microvascular fibula like this with an intramedullary wire, anastomose the peroneal artery to the radial artery, and then get him to unite like this with complete resolution of the problems. But the microvascular is not a panacea because this patient was sent to us. Actually, I think Professor Gadegone was kind enough to send this gentleman. And he had this huge gap and poor soft tissue. So I said, no, he deserves microvascular. In those days, I sent it to a colleague in Mumbai and he did an MRI angiography. And he said, no, the vessels are very poor. I'm not going to amputate this patient. I said, no way. This was just a trial to see how much the microvascular surgeon can do because the Elizaro can do much better. So we put on the fixator. We did multiple debridements until the wound was really good. We just skin grafted him and performed a proximal bone transport. The difference between microvascular and Elizaro is that the microvascular relies on the medium-sized vessels to be able to anastomose, whereas the Elizaro relies on whatever little vascularity is present, whatever little collateral vascularity is present, and it enhances the vascularity of the entire limb. And this is how he completely united and stays united and is able to attend to his business without any trouble whatsoever. So then what do you do when you have a failed microvascular? Like this gentleman who had a comminuted segmental tibia and he had a brachial plexus injury, multiple problems. So we debrided, put on the Elizaro fixator, spanned the limb, debrided him, got him ready for the microvascular. And unfortunately, the microvascular failed. This is the picture on the second day. So my friend, the microvascular surgeon says, amputate him. Don't be married to his flap. Don't be married to the limb. And the patient said, no way. If you have the patience and if you can do it, save my limb. So that's exactly what we did with the Elizaro. So with the infection controlled, with the femur and the foot fixed, we used minimal fixation with wires, to control the tiny slivers that were present posteriorly, allowed him to walk. And in a year and 6 months, this is his picture. The slivers of bone have completely healed up. He comes and sees me. He has his limb and is very grateful to the Elizaro method. What do you do when you have a failed microvascular and a failed bone transport? Everything was done for this patient. And then all we had to do was transport the fibula, bring the fibula medially, get it into the gap. We use these half pins and we also did it very gradually so that, the fibula came medially, he formed new bone behind so that there was a very good effect and he was able to solve his problems after 8 years of. I'll finally end this talk with 2 cases. Somebody lost his femur on the road, 17 centimeters. So then what do? It's very easy actually in this case because the soft tissues are intact and they present very little resistance to the lengthening. And you can have a massive length like this without any axial deviation, unlike the infected non-unions with fibrosis. And we healed all of his 17 centimeters. Finally, I'll share this case with you. This is a young student from IIT who was on a motorcycle. He lost, again, I think 18 or 19 centimeters. And this is what his enterprising surgeon did, I think in Raipur. It's a brilliant concept because the boy wanted knee range of motion. The surgeon said, if I'm going to put in this spacer for you, there is a chance that somebody can do it. So he went to 20 hospitals across the country. And, he was offered amputation in most places. And, this is how he came. He was in agony. He was a large gap, but the infection was controlled. So what we did was a combination of the LRS and the Elizaro. So marry the 2 advantages, of the Elizaro and the LRS. The LRS is very well tolerated in the femur and the Elizaro is brilliant in the tibia. So that's what I usually do. So we use the bone transport in the femur. You can see here very thin half pins to try and get a very good grip. And the Elizaro across over the nail, which is there in the tibia. And he got all of his, I think 23 centimeters of bone like this. And he's now awaiting treatment by some intrepid arthroplasty surgeon because this is what the young man wants. His gap is covered. There is no infection. And the Elizaro has done its job for the treatment of bone gaps. Right. Thank you very much again for your patient hearing and the kind invitation.
Thank you, Dr. Milind Chaudhary. That was wonderful. And it seems the problems of infected non-union with large gap can be very well managed with a strategy well planned out. And you very nicely gave a infection scoring system also. That is really very, very useful for such difficult cases. Any comments, Sangeet
Milind and Mangal, for both? You are a very brilliant and surgeons who saved lives and limbs of thousands of people. But one question I want to ask: what is the satisfaction quotient of a patient after your completion of a treatment? Not in the form of that he has saved the limb, but satisfaction quotient regarding the cosmesis and functional outcome for both.
So the satisfaction is an element. I think I would like to address it on 2 counts. One count is joint stiffness. If there is residual joint stiffness, the patient is very unhappy. And in so many of the infected femoral non-unions and the gaps, my second stage surgery is a cordyceps plastia and an arthrolysis. And so many of these patients, if they have not had intra-articular abnormalities, we are able to give them very good range of motion with the Jude's corticeplasty and arthrolysis. You don't touch the rectus femoris, but you make sure that the vastus intermediaris mostly and the intra-articular adhesions are taken care of. That enhances their, the satisfaction index dramatically. And one has to be well versed in doing this thing. And the second issue is neurovascular, whom to try and reconstruct. If the patient has a nerve injury and loss of sensation on the sole, then he's going to become a poor candidate, for satisfaction. And the third thing I want to add is the counseling of the patient before the treatment. I always tell them, this is going to take longer than you anticipate. And during the treatment, I force them to attend work in whichever capacity they can. They have to go out of the house and attend work. These are the three strategies which have helped keep the morale of the patients high and the satisfaction index, reasonable for these difficult problems.
So in one word, dil mange more is the usual patient's philosophy and psychology. So once they have walked, then they want something else and they would want still something else.
Exactly.
That, yeah.
So I agree with Milind, but you also have to look at, what are the choices you have. When a patient comes with an infected non-union, some of the difficult ones, are those patients going to be benefited better by an amputation or a reconstruction? That is the basic question. Now, satisfaction index in terms of, okay, knee stiff ho gaya, ankle stiff ho gaya, but what choice did that patient have if the knee was already damaged intra-articularly or the ankle was already damaged intra-articularly? There was no real choice. So if you're able to get it into a solid unit and the patient is able to weight bear on that and function, I think that is a good satisfaction, because the question what has been asked is a sort of comparison between two things. If a patient is willing, there are times actually when I may ask the patient to go and see, Autobock and stuff like that, when there is not going to be any movement or sensation is poor. Go and check that out, see, decide what you want. The patient has been under treatment at various places for 3, 4, 5 years. Go and look at that and see whether that is something that you are comfortable with, and then they can decide. But if they go for bone transport or whatever, I mean, something to get it healed, and there is stiffness, I don't worry that, is he satisfied or not. He is usually satisfied, I think.
Right.
Then next question, when you are putting the Ilizaro or external fixator like LRS, and how far you continue, because this treatment is going to last for a longer period of time, suppose it is 6 months, 9 months or 1 year. So do we advise some antibiotic bacteriostatic protocol so that to suppress the infection, or you don't give that antibiotic at all? In a parenteral form, it is out of question, but in oral form. And what about the use of analgesics and tranquilizer?
Antibiotics as needed, not continuously. And so firstly, I don't do it in one stage. Never treat these people in one stage. We found that if the infection is not completely taken care of, the Ilizarov becomes painful. The LRS is not well tolerated. So unless and until the infection is completely cured and the patient has been walking, I will frequently keep a lot of patients in plaster cast or braces, walking for several months before I accept them for treatment. If the CRP and the is not down, we don't start with the Ilizarov. So then the infection, then the antibiotics are given only if there is some specific pin track infection, etc. And this protocol is now more than 25 years I'm following. I just don't perform in the same stage. And about analgesics, I think the idea is that I think the best analgesic is a pair of spanners and a good pair of eyes and a little free time in your mind to analyze what's going on the X-ray. That's the best analgesic for the patient, because there is pain and there is a cause for pain. And if you just prescribe analgesics, it's not going to take care of it. You know, most often you find the cause of pain. There is a skin tenting in the pin side. The pins are loose in the bone. There's instability. And you know, sometimes you come across in these middle-aged patients who are borderline diabetic, they turn diabetic. And if the pins get infected and you're lending them doing a bone transport, the whole thing goes south. It's miserable. So you have to, you know, look at all these factors. So the pain is not just analgesia and analgesics. It's the process itself, the control that helps in keeping them reasonably free from pain.
And how is your infection control measures, or rather the pin track management? So is it patient done? The dresser is doing that, or the patient himself cleans the pins? So what is the protocol you're following?
I mean, when they go home, they have to learn to do it. And if they do it wrong and, you know, crust accumulates, then they get into trouble over a period of time. So we teach them. And these days when the relatives don't have so much patience and the patient is not, you know, really with it, it's an issue. Yes, these days we are seeing more difficulties with compliance, you know, with simple things. And yes, it is a fact. So some patients are also not good candidates. So I refuse some patients. I will not do bone transport on you.
So if you have any simple tips and tricks on pin site management or pin infection sites, and if you have a presentation with you, I think, can you share those slides? If you have, or Mangal sir has it.
I actually have a video on YouTube. Basically what we do is we teach them how to take care of the pins. A patient stays in hospital for a minimum of 5 days.
Okay.
In the sense that on the second day we do a dressing and we do the pin site dressing. Patient watches us. Meanwhile, they've been sort of given a link to that video. Second, we use only boiled and cooled water. No saline, no nothing. The only thing that has to be sterile there is the gauze piece. So patient washes hands, takes the gauze piece, dips it in boiled and cooled water, and then works out those crusts, which are, if there are any crusts, so that any serous rich, protein rich fluid which is inside should have the opportunity to come out. If it comes out, there is hardly any issue of infection. If it stays in, then that can get infected. So one of the sort of yardsticks for discharge will be, yes, patient is doing the pin site care properly. Now, despite that, occasionally patients will have trouble. One is they use a shortcut in terms of bandage liya, usko cut kiya aur fir use kiya. You know, so that can give rise to infection. So we insist that they use only sterile gauze pieces. Occasionally, poor patients who are unable to afford, what I ask them to do is, एक दिन के लिए कितना gauze piece लगता है? They can buy those gauze pieces in bulk, cut it up, and put it into paper envelopes. Each day's supply is packed into paper envelopes. And then we will take whatever 30-40 days worth, autoclave that, and give it back to them. So when they open, they use up that one set, and that way they can still maintain the this thing. But this is insisted that patient will take care of the pins, except areas which they can't reach, for example, that's a different issue. But local doctor का dresser या compounder आके dressing करेगा, it doesn't work. And more important, or rather equally important, is the fact that you should be able to put it in properly without thermal necrosis. So stop-start technique in terms of doing it appropriately. All of that, I think, is equally important. Right size of shank spin. So when we are doing transport, we are using the 6 mm tapering to 5 mm shank spin, not the 4.5 or not even the 5. They are not strong enough. They are okay for your 3-week, 4-week temporary external fixator. But for the long bone transports, a long time, where they take time, I think you should use the appropriate size of the shank spin.
Second reason is a loosening.
Yeah. But loosening usually is secondary to infection. Towards the end, if loosening happens because the patient is constantly weight bearing, and you see, clear sclerosis around, then 1 or 2 of those pins can be sacrificed. But if there is gross lysis around one pin, a sort of what we call a permeative lysis without a clear sclerotic edge, then I would take out that pin, but that's very, very rare. Take out the pin in under anesthesia, scrape it, send it for culture, and depending on where you are in the time frame, either sacrifice that pin or put in another pin in place of it.
Okay. So like for Elizaro wires, we have tensioning. So do you tension your pins for the LRS as well while tightening the bolts?
No. That is for the JES.
So that is for the JES one.
For the JES, where they talk about, what is the word? I forget the word now. You move the pins into one direction before you tighten it. I forget.
Yeah.
Pre-stress.
Pre-stressing.
Preload.
Yeah.
It's for the AO fixator. That doesn't work with this system.
So here, for this, it's not really required. In fact, we want that the pins have to be, in the LRS especially, we want that the pins have to be absolutely parallel to each other. What happens if you have pins which are not parallel to each other? One is slightly pushed this side, it causes more force onto that inner side, and then it will cause necrosis over there. So the ideal is to have all of them perfectly parallel to each other.
Okay. Sangeet, any questions from your side?
Partly that has been answered. Like both of them have been successful in operating multiple times, multiple operated those bad infected ones. But overall, if you see, if we offer them amputation, they are least resistant, particularly from our class of patients. They are not readily accepting amputation. And if you consider loss of livelihood, multiple number of surgeries, they cannot go back to their original jobs. The time required to maybe more than 1 year. Second, the adjacent contractures, the edema of the foot, the huge leg. Where do we stand today? If you have to balance in a earning member of a family, if you have to offer, in those multiple operated.
See, this question comes up, Sangeet, oftentimes in let's say a poor laborer's family, where the child has got some kind of congenital condition, which is going to require 2 and 3 things, 2 and 3 procedures, at least for treatment. There, some of these things, and there are other children who will additionally suffer because everything gets diverted to this child. So that is the commonest area where this kind of thought process occurs. Now, when a patient comes to me with all those things that you described, swollen foot, this, everything is stiff, there will be times when that option is offered to them. And say like myelomeningocele. Myelomeningocele, we can correct it with the Elizaro. It's not an infected non-union. So they will have an ulcer and stuff. But oftentimes what happens is that recurs, or the ulcer recurs, because there is a basic condition which is we are not treating. We are just straightening out the foot. So there, very seriously, I will sit down and discuss with the parents the option of amputation. So it's not that amputation is not a good solution in a small number of cases. What I object to is the flippant offering of amputation. And this is more common with UK trained surgeons. If you know, it is like, chalo, if I have failed 2 times, so now the option is amputation. Whereas if you have failed because you screwed up, then amputation is not the answer. But yes, in such certain situations like you described, you know, what I call a public hospital patient who's not able to afford, certainly these are things that are discussed and sometimes encouraged also. Even if the patient says that, no, I'm not willing, and I put it across. I think 2-3 weeks ago, actually, there was a patient from a prominent surgeon who was referred to me for Ilizarov. And that guy had his whole lateral portion of the distal third of the femur exposed, yellow. You know, you could see that the infection has gone into the
Joint.
joint. And so I explained all of this to him, that I'm going to have to exercise this. This is going to take so much time. You will not have flexion, meaning your knees is completely buggered essentially. So now you have to balance whether doing an amputation and getting a prosthesis with a knee is a better option to 2 years of treatment with a fusion at the end. And then patient said, I'll think about it, and then he has not come back. So I told him that amputation you can consider even locally. So it may be that he considered amputation, or maybe he thought that I was too, you know, crude to bring that up, whatever it is. But I mean, there are situations where I will place both. And I told him actively that I don't think that reconstruction is the right option for you.
I have a specific criteria. If the patient is not able to follow up regularly, if he has a wrong sense or a sense of entitlement that once he pays you a certain X amount of money, then it becomes your responsibility. If I get this feeling, I will refuse them and tell them that you are better off with an amputation. If they're going to take responsibility for their treatment, you know, it's going to work. The interesting thing I wanted to share was recently, the first time and the only time in my career, I've seen a patient with a 25-year-old non-union who developed a sarcomatous change. And we did the biopsy of the skin, even the skin, and then we offered and did the amputation. So amputation, yes, is part of our armamentarium. Definitely. Definitely.
With that, we come to the,
sorry.
With that, yes, sir.
No,
please.
I just wanted to ask Milind, infected non-union with an ulcer.
Yeah. He developed sarcomatous. I think it's called Marjolins.
I've seen 2 of those. Yeah.
And with that, we come to the last lecture of today's webinar. That is tips and tricks and recent advances in infected non-union. And that is going to be interesting, Sangeet. So we watch this last lecture.
So thank you, Dr. Chandak. So actually, it's not a very comprehensive talk. We have already spent a lot of time. I just wanted to introduce some concepts. One is, of course, we have in the last 10 or 15 years, the Western world has moved towards what's known as the diamond concept of Giannodis for the treatment of non-unions and for the treatment of infected non-unions, in which Professor Giannodis from Leeds, he has spearheaded this whole idea. And it is incumbent upon the fact that one is able to perform a complete debridement of, thorough debridement, get rid of the infection. And then they use stable fixation, bone graft substitutes, as well as BMP. So the BMP tends to form an integral part of the treatment of gap non-unions. Now, I have resisted for a really long time the use of bone morphogenetic protein with the concept that because for the first several years, for the first 15 or 20 years, I treated most non-unions even without bone grafting. We published our work in distal tibial non-unions without bone grafting. Vast majority of cases we've treated without bone grafting. So why use the BMP? In certain circumstances we come across, and I share with you, the energy impact of the trauma, that original trauma that caused the non-union, I think is a very big factor and sometimes doesn't go away. So I'll share a case of where we used this concept. This is a young lady who fell down from the balcony of her house and had this intermedullary nail, which the femur never united. And coming from, a rather certain socioeconomic class, she was unwilling for a proper Ilizarov resection of the bony ends and a proper bone transport and lengthening. So we thought we could get away by doing lengthening over a nail because her infection was quiescent. The infection was in the past. There was no current infection. So I chose to perform a lengthening over a nail. And little did I know that several things happened, and this is what we ended up doing. And she formed no bone whatsoever. What she really needed was a double level fixator assisted nailing, in which we should have compressed across the non-union surface and lengthened at another surface using a specially designed nail, like I have written up in my 2019 article in the British Journal of Bone and Joint Surgery. So we use special nails with central holes. So what we should have done was removed these cerclage wires, have a straight nail with extra holes over here, compressed at this level, locked at the upper and the middle levels, and lengthened through a corticotomy at the lower level, so that we would have achieved the length and union at the same time. But having made this mistake, for about 8 months, she was not forming any bone whatsoever. And because it was not a big issue for them, we chose to perform, upper tibial bone grafting. So here you can see the gel of the BMP has been inserted next to the muscle, deep in the wound. Bone grafts have been added, and then the BMP gel has been placed on top. And the nail was kept in situ because it was a stable fixation. And to my complete and utter surprise, she completely consolidated in less than 5 weeks. It's a fabulous bone formation, and she healed completely well with the BMP. Now, BMP is not easily available. People have worries about carcinogenic properties of the BMP. It's expensive. And so what do we do? For someone like me, I have to order it in advance. The technician comes with the packet of BMP and so on and so forth. So when we do not have access to BMP, how do we do this? And this is the only thing I would like to add, because infected non-unions is actually a huge topic, and we can spend a couple of days dealing with the various nuances and various aspects, various facets to this problem. So so I focus only on one treatment. If there is one treatment modality in the Ilizarov-LRS limb reconstruction that I wish I would have incorporated earlier in my practice, is the method of chipping treatment for non-unions. This treatment has come to us from Japan, from the city of Koriyama, from Professor Matsushita, who was the president of Japan Asami and hosted the Asami International in Kobe, I think Kyoto several years ago, I think 2004. And what he believes is that, we believe in, the osteogenic potential. He feels that the osteogenic cells are present all around in the non-union, and there is enough histologic work to prove that even in atrophic non-unions, osteogenic cells are present within the bone in the non-union site, and you need to give the definitive kind of stimulus. So here is an example of a young lad who had polytrauma. He had this, infected non-union of the femur with a supracutaneous plate with shortening of the limb, as well as, I'll talk to you later. And he has, the other side, he has, heterotopic ossification in the hip. He has a radial nerve palsy. after a healed fracture humerus on the opposite side, and he could barely stand. He was utterly miserable. And how to treat this femoral non-union? So what we ended up doing was we used the LRS fixator here. As I've told you before, I'm very fond of the LRS for the treatment of femoral non-unions. And instead of taking, because he had very few sites for bone grafting, they were all used up, and we could not have harvested graft from anywhere else. Plus, we wanted to achieve lengthening. So what we did was, at the level of the non-union, we performed the chipping treatment. Now, this is you take a heavy, sharp osteotome, and you make multiple, I take sometimes half an hour to do this, create multiple chips at the non-union site, extending a centimeter or two above and below. What that does is it sets up a hematoma. And regardless of whether this is an atrophic non-union. Of course, the important criteria is that the infection must have quietened down long ago, or it must be a non-infected non-union. So in acute infection, you can't do this. And then after that is done with stable fixation, we wait for a while, there's a latency period, and then we gradually, slowly distract at a much lower rate, at the rate of 1/4, 2 times. And this is how he went on to develop, not just, he got length, and regenerate also formed in this. You can see on the lateral X-ray, profuse regenerate has formed posteriorly. And this is how it's looking. It's almost completely united. He's walking on it after a couple of months. He got 6 centimeters of length. His limb lengths became equal. There was no need for bone grafting. And he did really well with this treatment. Solidly united with chipping treatment. No need for bone grafting. No need for additional extra, allografts or, commercially available grafts. Then we went ahead and did, resection of his hip heterotopic ossification to get him to, he's able to walk reasonably well with this, somebody who had never stood for a long time. And then we also did a set of tendon transfers for his, radial nerve palsy, which has enabled him. This is a bad video because he's got thumb abduction, but he's got wrist extension as well. And he's done well on all counts. Here is another man who came to us from far away. He had a horrid non-union of the femur with a nail which is completely loose in the bone, and the bone was a mere shell, a very severe infected non-union. Now, how do you treat this gentleman? All his bone graft sites were all used up. In the first stage, we used the multiple antibiotic coated rods from the non-union site as well as from above. And the infection was cured. Then we put him in the Ilizaroff fixator. Now look at, this is one tip that I have learned. This is the hash fixation. That's, we use 2 pins going up the neck and 2 pins coming down from the trochanter. And then we slowly got him to compress at the non-union site till he was well compressed on the AP view. And then what we found on the lateral view is that he's got an obliquity of the non-union surfaces. So we tried very hard to get this bone fragment to compress from posterior to anterior. We succeeded in achieving the compression, but we didn't succeed in achieving union. And we were almost at our wit's end. His bone was very soft. We had, extended the fixation to below the knee. And so therefore, finally, I resorted to chipping treatment. So through the same fixator, through a small 1.5 centimeter incision with a very thick and sharp osteotome, taking almost 35 to 40 minutes, we created multiple chips at the non-union site, breaking up all the sclerotic surfaces especially, and going a little bit into the normal bone above and below. We compressed it, had a long latency, and then slowly distracted very gradually to give him a very stable union. But we didn't lengthen him much because he was, you can see from his appearance, he wasn't very well nourished and he wasn't tolerating the fixator now. And we managed to solve the problem by the chipping treatment. So this is a very small tip that I wanted to share with you all. This is a very valuable addition to the non-union treatment. And Professor Matsushita has written up this in a couple of articles. And he also uses an intramedullary nail and then lengthen over the intramedullary nail and then lock it to reduce the fixator duration. Of course, this cannot be used in the presence of infection. If there was infection in the past, it must be completely dormant or taken care of. So, and it's very useful in sclerotic non-unions where it's very recalcitrant. So infected non-unions is a huge topic, and I really thank you for giving me an opportunity to share my experiences.
Thank you, Milind sir. That was wonderful. So is this chipping treatment same as clamshell osteotomy and no?
I think not. I think
No.
not. Clamshell, yeah. So I think
Clamshell is
Sandeep
totally
has-
different.
Okay.
It's a longitudinal osteotomy
Mhm.
for segmental correction
Okay. Perfect.
to
That was
accommodate.
so BMP is there in the literature since long. Our experience is not there basically because it is not available. Like the teriparatide became in India available and it was used extensively. So is BMP now available in India or you are getting it from Western sources?
Misused extensively.
Misused extensively, yes.
I use it very selectively, very judiciously. It is available. It's expensive. And Mangal knows better that it must be, I'm sure, is getting misused. I use it judiciously. First,
No, I was talking of teriparatide.
Teriparatide, yeah.
Moment
It
you
came.
know, something is not healing, then you get that haddi jod, teriparatide.
Yeah, all those
All
things
of
came
that
into picture.
first before anything else happens.
Even for that matter, BMP also in certain institute where I should not say this, rather it is not a right platform. Simple non-unions, they don't need BMP, which is about 1.25 to about 2 lakhs. They don't require that. Where the principles have failed primarily, whether it is a simple union or an infected non-union. So that is being misused because patient is covering up, or
so you mean to say it
covering up.
You mean to say it is only for recalcitrant non-union?
Yes.
Where everything else has been tried?
Right.
Yeah. Okay. So the methodology for using BMP for those who have never seen is to put it onto gel foam and then apply all along?
Yes, you have to have it adjacent to muscle. You use the two foams and you sandwich your bone grafts between the two gel foams on either side. Both of them are in contact with muscle and your graft is in between. That's the key. The BMP injection is put onto the gel and it becomes stable after 15 minutes. So then, but the gel must be in contact with muscle. That's the key factor here.
So the result you showed was globular all around. So you somehow managed it all around?
That alone does not work. You need an autograft for that.
Yes, autograft in between. Of course, autograft. Autograft in between the two layers but the gel has to be in contact with muscle.
Okay.
That's the key.
Perfect. Any closing comments from Mangal sir?
No, I think
Gadegone sir is muted. Unmute kara.
What is the difference, Milind, from chipping and chiseling?
Shingling.
Shingling, yes, that is a age-old ancient method, taught to us by Femista. We used it extensively in KM. Dr. Dheer, whose registrar I was in 1987. We treated a lot of non-unions. Osteoperiosteal shingles we created, especially when we did plating, and of course that has a role. But here we are taking in the Femista technique very thin shingles of cortical bone along with the periosteum and the soft tissues. And we are trying to keep the majority of the bone solidly intact. Just thin shingles are raised above and below. But in the chipping treatment, what actually Professor Matsushita is now doing is, this where they dig up the roads to create new roads and repair them. There is this pneumatic drill, this Atlas Copco and Ingersoll Rand, this heavy drill machine. He's created an instrument like that. It goes into the bone to make the chips, because otherwise I have to use a thick, big osteotome and keep hammering away for half an hour. It requires a lot of stamina. You'll be surprised to do this. It can take 30 minutes because you want to create small chips. You break up the entire non-union, not just the non-union, but a centimeter above and below it. You create a bag of chips all around. Then according to him, it allows the BMP to come out from, which is hidden within the the bone all around the non. It's there everywhere. So, make use of what you have. That kind of philosophy is fantastic. This is one modality I wish I had started using earlier.
Okay.
I think BMP is in both of you, in your hands. Mangal and Milind both have BMP. As soon as they start operating, BMC is out. There cannot be a non-union after you operate.
No, you will be surprised. I, for one, and I'm sure Milind also will agree, that there have been cases where things don't always go as planned. But the one proviso there is, most of the patients where I have found that I have not succeeded, when I sat down and looked at it, I am usually able to point out a cause within my own technique or what I did. Something was lacking in what I did in terms of giving that patient the whole treatment. And the next time around, I took care of those deficiencies and the patient healed.
Very kind of you, Sangeet, but Mangal is right. It's a learning experience. We're continuing to learn as we go along. And I have had a few failures. I have had at least 3-4 failures in the hundreds of TBA. I have had some failures in humeri. I have had patients in the femur who have, after a lot of attempts have said, "Sahib, tumhi khub kela पण आता पुरे, हे आता काढून टाका, मी आणि माझं नशीब." It happens. So we are not.
That is a seminar in itself.
Yes.
How I failed and how I recovered from it.
So final take-home point, Sangeet, is debridement and adequate stability and managing the bone gaps and then healing.
Yes, and not one. And one strategy will apply to all.
Yes.
Like as Milind has pointed out, it is a compliance of the patient. Now there is no putting a ring fixator in a non-compliant patient. You should look for other alternatives.
Yes.
And as Mangal has pointed out, the way how we improve the healing rate in a non-union once the debridement and all that has been taken care of. So both had a wonderful and beautiful lectures and a lot of points to learn, even for us.
Yes.
I hope everybody.
We can end, Sangeet.
Yes, sir.
So, Pramod, give vote of thanks. Unmute.
After the vote of thanks, I thank Dr. Gadegone sir for giving me chance of vote of thanks. I am thankful to Dr. R.M Chandak sir for organizing nice master class. I thank all respected faculties, Dr. Sangeet Gawhale sir, Dr. Mangal Parihar sir, and I thank Dr. Chaudhary sir also. Thank you very much. Over to Gadegone.
So thank you, sir. Again, we will see you and we'll have a better discussion on infected or atrophic non-union. Next topic, Chandak sir. Hello.
Yeah. Please.
Atrophic non-union. Sangeet, okay? Next topic will be a masterclass atrophic non-union of long bone and periarticular fracture. Okay?
Absolutely fine, sir. Absolutely fine.
Thank you very much, sir.
Thank you so much.
Thank you,
everyone. Thank you so much.
Bye-bye.
Yeah. Thank
See
you.
you.
Thank you so much. Thank you, OrthoTV, for organizing and beaming this program. And we hand over to OrthoTV again back. Rishi, if you are there listening, please stop streaming. So that was wonderful, Sangeet. From a full contact now, I will have to go mismatch contact.
The chosen speakers were fantastic.
Yes, no, but actually the mismatch is full contact.
Yeah,